Good evening, everyone. Today I'm going to speak about newer advances in medical management of glaucoma. In the next 7 minutes, I will be covering these topics. Conventional anti-glaucoma medications tend to target only either decrease in the aqueous production or increase in the uveoscleral outflow. The newer anti-glaucoma medications aim at decreasing the IOP by newer mechanisms of action, and they can be classically divided into three groups, which newer anti-glaucoma medications in clinical use, ongoing clinical medication, clinical trials, and preclinical trials. First, coming on to in clinical use, Rho kinase inhibitors are the first newer anti-glaucoma medications introduced. They were cytoskelically active agents, and they help in regulating the trabecular flow and increasing the trabecular flow, which is a newer mechanism of action. Rho A, B, and C are the family of G proteins, and the isoforms include ROC1 and ROC2. And there are two hypotheses for the mechanism of action. The first hypothesis being they increase the aqueous outflow and decrease the outflow resistance by increasing the ability of the Schlemm's canal endothelial cells to form pores. Second hypothesis being causing the relaxation of smooth muscle fibers in the trabecular meshwork, therefore increasing the outflow. Commercially available Rho kinase inhibitors are ripasudil and netasudil. Both work on ROC1 and ROC2 receptors, and the most commonly reported adverse events include the conjunctival hyperemia, blepharitis, and allergic conjunctivitis. Netasudil, in addition, have a norepinephrine transporter inhibitor action, which can cause the decrease in aqueous production, which was proved in animal studies. And Fasudil is a newer Rho kinase inhibitor undergoing clinical trials, and they act as a significant as an adjunctive therapy because the mechanism of action of these Rho kinase inhibitors is different from the pre-existing glaucoma medications. And other potential investigation routes include they help in neuroprotection by increasing the blood flow in the optic nerve, and a proposed role in preventing the post-surgical scarring. However, on the flip side, the side effect profile is relatively high, including conjunctival hyperemia, subconjunctival hemorrhage, and blepharitis, and this may prove to be a deterrent to long-term compliance with these medications. The safety efficacy of these in individuals below 18 years and pregnant and lactating women is not known. And apart from primary open-angle glaucoma and ocular hypertension, that their role in other types of glaucoma is still under investigation. Coming on to latoprostine Bunode, which is a unique nitric oxide donating prostaglandin F2 analog. Actually, it donates two active metabolites, latoprostic acid and nitric oxide, which have two different mechanisms of action. Latoprostic oxide acts like a prostaglandin analog, and it binds to prostaglandin F receptor, increases the uveoscleral outflow similar to prostaglandin. The nitric oxide, which tends to cause vasodilatation and smooth muscle relaxation, decreases the cell contractility and volume, thereby increasing the trabecular outflow. And thus, it is a single molecule which gives two active metabolites which act through two different pathways for reducing the intraocular pressure. And it is more evidence is awaited on its role as adjunctive therapy. It is currently dosed at once daily at bedtime like prostaglandin analogs. Safety profile is not yet established in case of pregnancy and lactation. And frequently reported adverse events include the same as that of prostaglandin analogs like conjunctival hyperemia, eyelash growth, and eye irritation. Coming on to newer drug delivery system, Jurista is the only approved new drug delivery system, which was approved in 2020. It is a sustained release biodegradable implant over a period of 90 days. It uses a specific Novadur drug delivery system for intracameral use, specifically using a 28 gauge single-use pre-filled applicator. And the drug delivery system is made of biodegradable polymers that disintegrate by hydrolysis into carbon dioxide and water. And the indications for this include open-angle glaucoma and ocular hypertension. Contraindications include active or suspected infection, corneal endothelial cell dystrophy, prior corneal transplantation, absent or ruptured posterior capsule, and individuals with history of hypersensitivity to bimetoprost. Although there are no adverse effects related to that of usual side effects related to bimetoprost, the main concern was a drop in corneal endothelial cell density. Newer drug delivery systems ongoing clinical trials include the bimetoprost ocular ring, which is silicone and polypropylene ring impregnated with bimetoprost and is designed for insertion between upper and lower fornices, continuously releasing bimetoprost for a period of about 6 months. Travoprost punctal plugs are also undergoing trials where there is a sustained delivery of travoprost over 90 days. Nanotechnology includes nanoparticles which are piggybacked onto the drug molecules, which have the ability to bypass the biological barriers and delivering the drug directly at the target site. And a number of nanotechnology these are available: subconjunctival injection of dorzolamide, supraciliary injection of brimonidine, etc. Investigational glaucoma medications include cannabinoids. Basically, they help in neuroprotective effect linked to the inhibition of glutamate release. Oral cannabinoids tend to have reported demonstrating the IOP reduction. Inhalational cannabinoids report a short duration of IOP reduction, and topical cannabinoids have failed to demonstrate significant effect of IOP in clinical trials. But on the flip side, the relatively short duration of action, risk of developing tachyphylaxis, serious side effects impacting patients' general and neurocognitive health outweigh the potential benefit of this. Coming on to the neuroprotection in glaucoma, which is considered to be the holy grail of glaucoma care. Neuroprotection in glaucoma refers to any non-IOP related intervention that can prevent or delay glaucomatous neurodegeneration independent of IOP. Most important thing in that is the neurotrophins, which have a key role in cell survival. These include brain-derived neurotropic factor, ciliary neurotropic factor, glial cell line derived neurotropic factor, and nerve growth factor. And valproic acid, which is commonly used in treating epilepsy, has also been demonstrated to have neuroprotective effect. However, no human trials are done so far. Coming on to memantine, it's an NMDA receptor antagonist and can prevent cell death by calcium influx. Brimonidine, apart from the IOP lowering effect, has a neuroprotective effect involving upregulation of anti-apotopic factors, modulation of glutamate-induced excitotoxicity, inhibition of nitric oxide synthetase, and inhibition of glial activity. Alternative medicine, dietary supplementation with alpha-lipoic acid has shown to decrease oxidative stress. Flavonoids like ginkgo biloba have been demonstrated a positive effect on ocular blood flow, and oral ceticolin has been shown to improve as visual function. Gene therapy still in early stages. Disruption of aquaporin 1 by gene therapy has been going on in animal studies. Adenovirus gene therapy has been also undergoing animal studies. Stem cell therapy helps in regenerating and repopulating retinal ganglion cells and possibly restoring vision lost from glaucoma. And yoga and lifestyle changes. Current literature doesn't prove any evidence to support yoga relaxation techniques in arresting or progression of glaucoma. However, reduction of IOP was noted with certain yoga practices, and certain yoga practices, as shown in this figure, have shown to cause an increase in IOP shortly after beginning. Thank you.